My name is Susan Ward, and I am an ambassador for the Family Heart Foundation. I am also a nationally board certified health and wellness coach and certified lifestyle coach for the National Diabetes Prevention Program. And I am also someone who has elevated lipoprotein little a. This meeting is a monthly meeting that we host under the auspices of the Family Heart Foundation, and it is called Empower LP little a. And tonight our program is titled Brain Fat Matters, Understanding Lipids in Neurology, with our featured guest speakers, Dr. Thomas Dayspring, clinical lipidologist, and Dr. Kellyanne Niotis, preventive neurologist. I'd like to say that we have quite a collection of people from all over the world. We're expecting attendees from the UK, in England, in Australia. We have residents of Canada and the United States attending tonight. We also have onboarding from the Family Heart Foundation, Hilly Page, the Chief Information Officer, Ann Dodge and Eric Tricou, care navigators who work with all the people who call in with questions and need help finding the right cardiologist and lipidologist, and Jen Farnell, the Director of Community Outreach, who is working with me tonight to co-host this meeting. The balance of people from the Family Heart Foundation are ambassadors like myself and LPA support group members. We also have on this call many followers of Dr. Dayspring, approximately 20 medical doctors. We have several pharmacists, lab scientists, health and wellness coaches, and many others. And I know that Dr. Dayspring will give a shout out later to some of his colleagues who are here tonight. So I would like to thank and gratefully acknowledge the generous support of the sponsors of the 2025 LP little a Community Activation Program and LPA Awareness Day. And those include Lilly, Novartis, and Amgen. Thank you for your support. And now a brief medical disclaimer. Today's program is for your information and educational purposes only. The content is not intended to be a substitute for professional advice, diagnosis, or treatment, nor does your participation constitute a medical or coaching relationship with the presenters or employees or officers of the Family Heart Foundation. Future research may impact today's presentation. Information may be updated or changed in subsequent presentations. Follow up with your medical professional for specific recommendations pertaining to your or your family member's diagnosis or treatment. And again, we usually tell everyone to reach out to a Family Heart Foundation care navigation specialist for further resources. I would like to introduce our amazing guests. And I want to say before I say another word about them, that I discovered them first doing a podcast with the Australian Simon Hill, whose podcast, The Proof, is one that I have listened to. And I think I've listened to at least 4 or 5 lectures with Dr. Dayspring. But this particular one was a particular interest because it featured Dr. Kellyanne Niotis, preventive neurologist with Dr. Tom. So Dr. Niotis is the first fellowship-trained preventive neurologist specializing in risk reduction strategies for neurodegenerative disorders, including Alzheimer's disease, Lewy body dementia, and Parkinson's disease. She completed her medical internship and neurology residency at New York Presbyterian Weill Cornell Medical Center. serving as chief resident and the inaugural McGraw Fellow in Neurology Research. Additionally, she completed a fellowship in movement disorders at the Icahn School of Medicine at Mount Sinai. Dr. Niotis led the preventive neurology program within early medical and managed the country's first Alzheimer's prevention clinic at Weill Cornell Medical College, New York Presbyterian Hospital, where she developed research programs for Parkinson's and Lewy body dementia prevention. In addition, Dr. Niotis is the director of Parkinson's and Lewy body dementia research at the Institute for Neurodegenerative Diseases in Florida, where she studies early detection and personalized risk reduction interventions for people at risk for neurodegenerative diseases. Her work has been published in many notable medical journals, including Neurology, Nature Mental Health, Frontiers of Aging Neuroscience, Aging and Disease, Movement Disorders, Journal of Alzheimer's Disease, Alzheimer's and Dementia, and Journal of the Prevention of Alzheimer's Disease, and has been presented at national and international conferences. She is passionate about the budding medical space of preventive neurology, in particular pertaining to the advocacy of preventive neurology policy changes and making treatment and education more accessible to the masses. She has received numerous honors and awards, and her opinions have been featured in popular media outlets. I would really like to, it's my greatest honor to welcome Dr. Niotis to our presentation this evening. And now I'd like to quickly get to our next guest, who you're all very familiar with, Dr. Thomas Dayspring, clinical lipidologist. He is a fellow of both the American College of Physicians and National Lipid Association, and certified in internal medicine and clinical lipidology. After practicing in New Jersey for 37 years, he relocated to Virginia and served as an educational director for a nonprofit cardiovascular foundation, and later as a chief academic advisor for two major cardiovascular laboratories. Currently, he is a cardiovascular educational researcher and clinical lipidologist at a select practice. Career-wide, he has given over 4,000 domestic and international lectures, including over 600 continuing medical education programs in atherothrombosis, lipids and lipoproteins and their treatment, vascular biology, biomarker testing, and women's cardiovascular issues. He has authored several manuscripts and lipid textbook chapters and performed several podcasts, and served as an associate editor of the Journal of Clinical Lipidology. He was the recipient of the 2011 National Lipid Association's President's Award for Services to Clinical Lipidology, and has well over 16,000 followers on his educational Twitter feed at Dr. Lipid. And with that, I would like to introduce our two guests who are going to give us more of a, well, they were calling it a fireside chat, but I think it's summer now, so we'll just call it a very informal and wonderful lecture. And I will stop sharing my screen at this point and let you two have the floor. So Jen and I will disappear and we'll be back later. Welcome to both of you.
Thank you, everyone, for having us here today. One thing that I think we should emphasize is just how unique of a combination this is to see a neurologist and a lipidologist together. Just to tell a little story, to go a little deeper into this weird relationship, I had been consuming things that Tom had been putting out there in this space for so long before I had the pleasure and true blessing of meeting him. And the first time I got to interact with him, I had a whole list of questions based on things I'd see in the literature about associations with triglycerides and cholesterol levels and Parkinson's disease that no one could seem to give me any meaningful information about. And it turns out that not a lot of people know much about brain lipidology. So it put us down this pathway of really learning together. And I would be a fool not to admit that we're still learning so much about this space, and there's still so much to be uncovered. We're just really getting started with this.
Yeah, all I can add is, I'm an old man, been around a long time, and have met so many incredible lipid folks around the world. Some of them are on tonight's podcast listening in, and that honors me. But you wouldn't think it'd be tough to excite an old man anymore. But when I also first met Kellyanne at that early medical practice where we were both, it was just wow, like magnets picking up pieces of metal. We drew to each other so incredibly well. And just before that, I had heard Dan Rader, a master lipidologist. Uh, Somebody asked him, where's lipidology going? What's next? And Dan said it's the brain and lipids, which we really don't know anything about, but we better learn it because of this epidemic of neurologic diseases that are coming down. So whatever brought us together was great fortune, but it made me hit the literature and stuff again in an area which I had never really looked at before, and that is the brain. And Kellyanne knew everything about all those cells in the brain and what they do, but not so much about lipids. But what a happy academic marriage this has been, and we've put a lot of great stuff together. So I hope we can instill our enthusiasm to everybody listening tonight.
Yeah. So I thought I would kick it off because most people attending this really have a background in cardiology or lipidology. I thought I would kick it off just giving us a basic overview on what the heck neurodegenerative diseases are and kind of focus in on risk factors for neurodegenerative diseases and so forth. So as Susan said in my introduction, I have a quite unique background because in the field of neurology, we really are pretty segregated. The cognitive disorder neurologists are in one bubble, and the movement disorder neurologists are in another bubble, and we're all very good at treating our particular disease. But when we think about prevention, we have to realize that these diseases share a lot of commonalities and a lot of the same risk factors. So when we want to prevent a disease, we really have to think of them more collectively than has been classically viewed. So what are neurodegenerative diseases? There are lots of different types of neurodegenerative diseases. There are neurodegenerative diseases that can affect our peripheral nervous system. Those things are things such as ALS or Lou Gehrig's disease. There are other neurodegenerative diseases that primarily affect our central nervous system, and these are things like Alzheimer's disease, Parkinson's disease, and Lewy body dementia, vascular dementia, frontotemporal dementia. There's a lot of other more uncommon types that fall into this category. My primary focus is on the more central neurodegenerative diseases and mainly the most common forms, and those are Alzheimer's disease, Lewy body dementia, vascular dementia, and Parkinson's disease. Of those, Alzheimer's disease is by far the most common form of neurodegenerative disease. It makes up about somewhere between 60 and 80% of neurodegenerative diseases. And that's followed by Lewy body dementia and Parkinson's. So for the most part, what we're going to talk about and focus on in this particular conversation is this broader category of dementia, which really is encompassing Alzheimer's disease and Lewy body dementia and vascular dementia. Those are really what we're going to talk mostly about. So I am sure that many of you who are listening have been touched in some way with a neurodegenerative disease in your family or with a loved one. So I'm sure a lot of you are very familiar with the common signs and symptoms of neurodegenerative diseases and Alzheimer's disease in particular. But I thought it would be helpful to kind of review those because a lot of times it can be a little unclear when we hear a family history of cognitive decline, what that really means. Was it normal aging or was it something more serious? So in Alzheimer's disease, really the most common symptom is memory loss. And that is memory loss for more recent memories, with long-term memory or childhood memories, early adulthood memories often preserved. things like behavioral disturbances, personality changes, paranoia, hallucinations can happen in Alzheimer's disease, but they typically don't happen until later on in the disease course. When we think about something like Lewy body dementia or Alzheimer's disease, or Parkinson's disease, which also often is associated with a form of dementia in about 80% of patients, we're really talking about issues with visual spatial planning or understanding 3D relationships between objects and understanding or visual processing. And Lewy body and Parkinson's involve like motor issues, so tremor, stiffness, slowness, and so forth. So hopefully everyone can recognize that there's some distinct differences there. And then when we think about pathologically, Alzheimer's disease, and this will come up a lot in this talk, is associated with certain pathological proteins. And those proteins are mainly amyloid beta proteins and tau and various isoforms of tau proteins. Amyloid beta forms these plaques in the brain, and tau proteins form these tangles in the brain. And then Parkinson's disease is associated with, and Lewy body associated with something called alpha-synuclein, which forms these distinct entities called Lewy bodies in the brain, and can actually also be seen in the peripheral nervous system as well. One big misconception, and something that I hear all the time, is that, these diseases are diseases of the old, and we shouldn't worry about them until we're in our 60s, 70s, or 80s. And that is a huge misconception. We know that these diseases can start decades before the first obvious symptom. And in some people, that could be in their 30s or 40s, because these diseases can start early in some people. So when we think about how to prevent them, preventing them is a lifelong process. We have to start as early as possible, but I also like to emphasize that it's never too late to start. Even if you already are exhibiting signs and symptoms, there's undoubtedly something that you can do to change the way that the disease is progressing. And we now finally understand that prevention works. A lot of the work that we were doing at Weill Cornell involved using a precision medicine approach and studying our interventions for risk reduction in real time. And at the time when we first started our research, it was really taboo to talk about prevention in Alzheimer's or prevention in dementia in the same sentence, but the world has come very far since then. The Lancet Commission is a really notable medical journal, as everyone I'm sure is very familiar, and they finally published in 2017 for the first time that a portion of dementia cases could be preventable by addressing, I think at the time it was 10 modifiable risk factors, and then it went up to 12, and then it went up to 14 most recently in 2024. So we're going to talk about some of those things shortly. Tom, do you have anything else to add? I know that's not really your wheelhouse as much.
No, you did a great description on them as usual. Obviously, I've been much more familiar with my academic travels with vascular dementia and stroke or multiple strokes leading to cognitive issues or so. But all those other diseases you have mentioned, for much of my career, we were of the mindset, there's nothing you can do about them. Who cares? Don't do any testing for that. And just as in atherosclerosis, everything has sort of shifted from secondary prevention to primary prevention, and now what we call primordial prevention. As early in life as possible, try to identify modifiable risk factors and then go after them. Do not wait for any sort of actual disease to be present or so. So there's two similarities in your preventive neurology and where much of the lipid world is going into preventive vascular disease, mostly atherosclerosis.
Yeah. So just thinking about what are some risk factors for dementia. So the Lancet Commission published on 14 most recently in 2024, and I'll rattle those off because it's always helpful to hear them, and everyone should make sure that they're addressing all of these things. So they're traumatic brain injury or concussion, and that does not have to be severe concussion, less education or having lower educational attainment or lower quality education, hearing loss, vision loss, high blood pressure, hypertension, obesity, excessive alcohol use, smoking, depression, social isolation, air pollution, diabetes, and most recently, it took until 2024 for this to be recognized, elevated LDL-C. And we're definitely going to do a double click on that in this talk. What other risk factors do we think about? So, of course, age is the biggest risk factor. The older you are, the more likely you are to get any neurodegenerative disease. But family history is also a big one. And when we talk about family history, it matters who in your family is affected by it. First degree relatives are more impactful for your own risk. But if you have multiple family members impacted by a neurodegenerative disease, that also increases your own risk. And from experience, it is not uncommon to hear a family history of multiple different types of neurodegenerative diseases, Parkinson's, Alzheimer's, vascular dementia, and that really goes back to what I was saying in the very beginning about how these diseases really share a lot of risk factors, including genetic risk factors, which is another really big one that we want to talk about. So when we think about genetics, these diseases are polygenic, meaning there are lots of different genes that influence someone's risk for developing a neurodegenerative disease. There are a couple of genes that are highly penetrant, meaning if you inherit the gene, the likelihood that you'll develop one of these diseases is extremely high. But in most cases, that's not what we see. These genes are very rare. In most cases, we see multiple lower risk genes. And one of the most significant genes that we think about when we're talking about Alzheimer's disease and Lewy body dementia is something called ApoE4, which I'm sure a lot of you, since most of you are big health consumers in this space, have heard about. And I'll talk a little bit about ApoE4 and how that increases risk for neurodegenerative disease. And then I'll turn the table over to Tom to talk more about how ApoE4 impacts cardiovascular disease risk, because it impacts both. So ApoE4 or ApoE, apolipoprotein E, is a gene that encodes the protein ApoE. And this protein is, as Tom will explain more closely, heavily involved in cholesterol transport throughout the body, but it's especially important to cholesterol transport in the brain. It's also involved with the inflammatory process, with handling of toxic proteins and clearance of toxic proteins like amyloid and tau that we spoke about. Everyone gets 2 copies of this gene. You get one from your mom, one from your dad, and that gives us what we call a genotype. So ApoE, the protein, comes in 3 different forms, isoforms or variants or alleles. They're called ApoE2, ApoE3, and ApoE4. And these different variants differ by a single amino acid substitution, which dramatically changes the way that the protein behaves and interacts with LDL receptors in the body. Tom, can I turn it over to you?
Sure. I think I know what ApoE is. APO stands an abbreviation for apoprotein or apolipoprotein. I make the distinction that an apoprotein is simply a protein that is looking to attach to something. And if it attaches to lipids, it's an apolipoprotein. And if it attaches to a lot of lipids, it creates a little water-soluble lipid transportation vehicle called a lipoprotein. And there's 2 organs in the body that produce apolipoprotein E, and obviously one of those is the brain, and the other one is the liver. Interestingly, the intestinal cells do not produce ApoE, even though they produce particles that carry many copies of apoprotein E, the chylomicrons. So anyway, apoproteins, there are several of them that can be on various types of lipoproteins, and they serve a lot of functions, structure, stability, and they serve as ligands for specific receptors that might make a lipoprotein particle bind to something, both in the brain and in the peripheral circulation. So in the periphery, you will find mostly apoprotein E on HDLs, which is just the transient carrier of ApoE, and it sheds them, it transfers them to other particles that really need them. And the particles that really need them are your triglyceride-rich carrying particles that come out of the intestine, chylomicrons, or come out of the liver, very low-density lipoproteins. Their mission in life is to deliver triglycerides to muscle beds or adipocyte beds, where the triglycerides can be deesterified and the fatty acids can go into muscles where they're oxidized for energy, or go into adipocytes where they're stored as reassembled triglycerides for future energy needs. Once those particles deliver their triglycerides, they become much smaller and they're mostly carrying cholesterol. Now, each of those particles, chilos and VLDLs, carry several copies of apoprotein E. It's not like ApoB, which most of you know, there's one ApoB per ApoB particle. ApoE can be in several copies on the VLDLs and chylomicrons. When they start getting smaller, the ApoE conformation changes and they become a ligand for a couple of receptors that the liver expresses. The triglyceride-rich particles, once they've lost the trigs, as they get smaller, the ApoBe makes them bind to something called an LDL receptor-related protein, LRP. And that is how chylomicrons carrying your absorbed cholesterol get pulled into the liver, because ApoE binds to the LRP. And that is how VLDLs, once they've delivered your triglycerides, they don't deliver cholesterol anywhere. They are rapidly cleared by the liver by LRP also. ApoE can also be a ligand for an LDL receptor. Now, LDL particles carry few, if any, copies of apoprotein E in the vast majority of people. HDLs carry it, and believe it or not, an LDL receptor can actually clear a certain size HDL particle that has copies of ApoE sticking out, and an LDL can enter into the liver through an LDL receptor. It's not the most common way it gets in, but it can. So ApoE in the periphery serves as a, hey, how do we clear these particles once they deliver trigs? As Kellyanne mentioned, ApoE comes in different isoforms. ApoE2, ApoE3, ApoE4, or various combinations of any of those, so it can get kind of complicated. There are multiple ApoE genotypes. Interestingly, those VLDLs and chilos that are returning cholesterol to the liver, if they express ApoE4, that has tremendous affinity for those receptors, and they get cleared very easily, very rapidly, and thus deliver their cholesterol to the liver. Now, the liver, therefore, accumulates cholesterol very quickly in E4 patients. But once it gets an X amount of cholesterol, the liver says, I don't want any more cholesterol. The liver downregulates LDL receptors. So therefore, there is far less clearance of LDLs, which only have ApoB100 on them, not any ApoE. And if you prolong the residence time, decrease the clearance of LDL particles, you send LDLP, LDL particle content through the roof, ApoB through the roof, and LDL cholesterol or non-HDL cholesterol, if that's what you're looking at. We know from numerous studies, people who carry one or two ApoE4 alleles have increased LDL cholesterol, and more importantly, significantly increased risk for atherosclerotic vascular diseases. So that's the E4 situation. Now, ApoE2, we're not going to spend a lot of time on that tonight, but if you get that in the periphery, you have ApoE2, that has terrible binding affinity to the LRP that should be clearing chylomicrons and VLDLs. So therefore, there's less cholesterol being delivered to the liver. The liver rapidly upregulates LDL receptors and rapidly clears the LDL particles. So paradoxically, ApoE2 with terrible binding affinity to the LRP has very low LDL cholesterol, very low ApoB, and much lower risk of atherosclerotic heart disease, where ApoE4, which has tremendous binding affinity to those receptors, pollutes the liver with cholesterol that therefore does not want to clear LDL particles anymore. And the last thing I'll tell you about that, we certainly have noticed a big association for those who carry one or two ApoE4 alleles, that they have significant hyperabsorption of cholesterol. Now, I'm not sure we understand exactly why, but I always tell clinicians, if you have an ApoE genotype in your patient and you see they're carrying an E4 allele, take a quick look at their LDL cholesterol. And if it's high, you might presume that they're a hyperabsorber of cholesterol. And if those patients require lipid modulating therapy, it wouldn't be unreasonable to start ezetimibe rather than a statin as the first line drug. For those of us who do measure markers of absorption and cholesterol, it's easy to figure out, but the overwhelming majority of people are not measuring those biomarkers. So that's ApoE in the periphery, Kellyanne.
And just thinking about in the brain. So what we understand, and we're going to get a little bit more granular about this, but the overall big picture is that as we age, maybe I'll even rewind. So there are two really primary types of brain cells. We have neurons, which are the cells that are connecting to each other and sending really swift signals involved with our memory, our movement, and so forth. The primary brain cell is called a neuron. And then there are these supporting cells for the neurons that help with inflammation and supporting getting neurons all of the important things that they need, like lipids, cholesterol, and so forth, phospholipids. And those are really our astrocytes or glial cells. With age, we actually shift where in our brain cholesterol is made. So if we didn't emphasize this enough, the brain has to make all of its own cholesterol. It doesn't get its cholesterol from the periphery. It's not taking up LDL cholesterol or ApoB cholesterol and using that in any way for any important neurological processes. It is making its own cholesterol. So as we age, cholesterol synthesis really shifts from the neurons to the astrocytes. So the neurons become very, very dependent on the astrocytes for delivering cholesterol, lipids, phospholipids for lots of important brain processes, creating neurotransmitters and so forth. It does that, and Tom's going to show us some beautiful visuals soon. It does that really through transport with ApoE4 or ApoE. And it turns out that ApoE4 is not as efficient at delivering neurons cholesterol or lipids. So things can get a little sticky and stuck inside the astrocytes and not get out and cause cytotoxicity or cell death, because when lipids start accumulating into cells, it can cause major issues. So maybe we should go to that section next. Yeah.
So that's back to me, I guess.
Yeah.
So,
well, should we well, let me actually comment one last thing. The
yes.
last thing is that, when we think about ApoE4 and how it increases risk for neurodegenerative disease, I'm often asked, like, how much does ApoE4 increase my risk? And the answer is really tricky. There was a study about a year ago now that really caused a lot of undue anxiety and stress for people who carried 2 copies of the ApoE4 gene. And it pretty much showed that ApoE44 was highly penetrant. And essentially, if you had ApoE44, there was just no chance you weren't going to get Alzheimer's disease. And unfortunately, that study had so many problems. It was really a poor study design and a very biased sampling. So I will say that it's impossible to know exactly how much ApoE4 increases your risk. We know having 1 copy increases risk a little bit, somewhere on the order of 2 to 4-fold of both Alzheimer's and Lewy body dementia. And then having 2 copies increases risk somewhere 8 to 10-fold, but I'm always so hesitant to rattle off those numbers because I do really think it depends on so many other individual factors. And I don't find that those numbers are really helpful for most people.
Okay. So picking up this cholesterol story in the brain is the second most cholesterol-rich organ in the body, with the liver being the first, but they're very, very close. It's not like the liver is miles ahead with way more cholesterol than the brain. But as Kellyanne mentioned, the brain gets all of its cholesterol starting in utero and continuing during childhood and then throughout adulthood by synthesis, de novo synthesis of cholesterol. The brain does not get a single molecule of cholesterol that is floating in your plasma. And of course, where do we measure cholesterol when we evaluate patients? Very few of us stick a needle in the brain and try and figure out what cholesterol is up there. Very few of us are doing spinal taps looking for various lipoproteins in the cerebral spinal fluid. We draw blood out of a vein in the arm. So you're looking at plasma cholesterol. Total cholesterol is VLDL cholesterol plus LDL cholesterol plus HDL cholesterol. It's really ApoB cholesterol, VLDLs, IDLs, LDLs, plus ApoA1, HDL cholesterol. And that has zero relationship to anything going on in the brain. So, in lipidology and atherosclerosis treatment, we're all trying to lower ApoB and LDL cholesterol extremely aggressively. And we have drugs now used in high-risk people that can make your LDL cholesterol 10, 14, 20, and people get very nervous. They go on Google and they stop their lipid modulating therapy. They talk to uninformed doctors who say, I'm not comfortable with that. I'm worried about your brain. You can never make any brain estimations based on any plasma cholesterol metric. So stop doing that, because the lipoproteins trafficking cholesterol in your brain are much too big to cross the blood-brain barrier and therefore enter the brain interstitial tissue. So if there's cholesterol in the brain, and there's a lot of it, it's all synthesized. Most of it is synthesized between birth and the age of 10. By then, your brain size is about normal, and much of that cholesterol production is going into myelination, all the coding of all our axons and dendrites and cells up in the brain or so. And that's pretty much complete by that time. So up until age 10, most of the glial cells and the neurons, a glial cell is any cell that's not a neuron, are seriously producing cholesterol. But around the age of 10, neurons need a lot of energy to create all those electrical discharges they make at the synapses so we can all move and have a heartbeat and think and see. So believe it or not, to generate one cholesterol molecule via synthesis consumes 27 molecules of ATP. That is a major energy loss. So evolutionists figured, hey, the neurons need ATP for all those electrical discharges they're doing. The neuron can't be wasting time making cholesterol. So once all myelination is done, the cholesterol production gets shoved over to other cells. Now, oligodendrocytes keep forming myelin forever. The major cholesterol producer in the brain is a glial cell called astrocytes. And they make cholesterol. I'm going to show you a nice diagram in a minute. And they ship it over to the neurons. And it is the astrocytes that supply the cholesterol. And then cholesterol, once it's used, gets recycled all the time in the brain. It doesn't have, or a little bit more is made. Thus, the half-life of a cholesterol molecule in the brain is about 5 years, whereas the half-life of a cholesterol molecule in our peripheral circulation is about 3 to 4 days. So that is because all our cells in the body can keep making all the cholesterol they want, and the liver makes it, the liver gets it, it clears excess. Different homeostasis in the periphery than there is in the brain. So understand that don't measure cholesterol in the periphery and think you know what's happening in the brain. Don't worry if you're going to use a lipid modulating drug, statins, ezetimibe, bempedoic acid, or PCSK9 inhibitors, and you're going to really lower LDL cholesterol, that you could possibly be injuring the brain. You cannot. So now let me talk about, in the periphery, it's the intestine and the liver shooting out ApoB containing particles carrying triglycerides and cholesterol, and they deliver the trigs to where the muscles and fat cells, and then they come back. The LDL circulate around for several days, just sitting there waiting to garner cholesterol from HDL cholesterol. HDL, which sucks it out of cells that don't want it, transfers it to the LDL, which brings it back to the liver. So the LDL ApoB particle performs reverse cholesterol transport. So there are no ApoB particles in the brain. The brain cannot produce apolipoprotein B. But trust me, the brain has a lipoprotein system. So let me show you a couple of slides now, if we can bring them up. And we're going to start with this one. Now, on the left, you see an astrocyte. I wish I could have these in animated form and you would see them one step at a time. But let's start way over on the left. And you see cholesterol synthesis via the block pathway. Those who have listened to me many times know cells uh, divert cholesterol synthesis into two distinct pathways. And one is called the block pathway, and this is the predominant pathway in the brains. In the periphery, it goes through a different pathway called the Can-Dutch-Russell pathway, which goes through a sterol called lithosterol. And you'll see that doesn't typically happen in the brain. So when you go through this 37-step process of cholesterol synthesis, the penultimate sterol, the next to the last sterol that through one enzymatic action becomes cholesterol, is called desmosterol. So if astrocytes are making cholesterol, just before they make cholesterol, they make desmosterol, and then they make cholesterol. And remember, they're making it primarily for their own cell membranes, but they know they have to get it over to the neuron because the neuron cell membranes are crucial to what a neuron does. And if you want to have a functional neuronal cell membrane, you better be sending it a lot of cholesterol so it positions itself there along with phospholipids. So how does an astrocyte get cholesterol over to the neuron? So in this picture, you see the astrocyte cell, and then you see sort of a greenish background. That is the brain interstitial tissue. It's called the matrosome. And this, remember, when the brain is going to create lipoproteins, it doesn't put them in your plasma, which takes them over to the neuron. Brain lipids and lipoproteins do not, under any circumstances, traffic in our arterial or venous systems. It travels in particles through the brain matrosome. So look up top. You see, wow, the astrocyte has synthesized a lot of cholesterol. Those little vesicles that it's in is the Niemann-Pick endosomes, which are transferring it up top. You see an ATP binding cassette transporter A1. That is a cholesterol efflux transporter that takes free cholesterol and effluxes it into a cholesterol acceptor protein. And what is the apoprotein that the astrocyte produces? Apolipoprotein E. No ApoB, no apoprotein A1, which is on HDL particles in the periphery. It's ApoE. So ApoE can be secreted by itself into the matrosome, and it just swims up. It's a few nanometers away, if that, to binds to an ABCA1 and starts accepting free cholesterol that the astrocyte is extruding. And before you know it, the ApoE becomes lipidated with molecules of cholesterol. They actually get esterified just as they would in the periphery with an enzyme, lesser than cholesterol ester transfer protein. So, and then you find a big mature HDL particle. You see, it's called a lipidated ApoE containing HDL. Now, wait a minute, HDL, isn't that from the plasma? No. The lipoproteins in the brain have the same buoyancy or density as peripheral HDL particles. So if I put in brain lipoproteins in a centrifuge and I put peripheral lipoproteins in a centrifuge, those that went down to have a density within a certain range, a very high range, are called high density lipoproteins. Never confuse the HDLs that the brain is forming with the HDLs in the plasma, other than they have similar buoyancy and density. There's other big differences. The main apoprotein of brain HDLs is apoprotein, apolipoprotein E, whereas in the plasma, it's apolipoprotein A1. And you can have 2, 3, 4, or even 5 copies of ApoA1 on the periphery. The brain HDLs can have more than one copy of ApoE also. Now, also, we're not done. That is one way of forming brain ApoE containing HDL particles. But notice the astrocyte itself, since it's making ApoE, can actually lipidate ApoE within the cytosol of the astrocyte, creating a high-density ApoE containing particle, which the astrocyte just secretes. And so there's two ways a brain HDL can be formed. And once it's in the matrosome, it's going to swim over to, and if I could have the next slide, Kellyanne. Okay, so you see astrocytes. I threw in a microglia. Those are brain immune cells, but they also can accept cholesterol and make a little bit also. It's a different type of glial cell. So now focus on the right. You see the neurons there, but let's look at the neuron cell membranes. You see a lot of phospholipids there. It's a bilayer membrane, but a lot of cholesterol has to get into those membranes. So how does the neuron get the cholesterol that is in the brain ApoE particles swimming around the matrosome? One, up top, the brain can express an LDL receptor, has definite affinity for ApoE, so that can internalize the entire ApoE HDL particle into the neuron, where it enters an endosome. The second receptor, colored blue in my graphic, is the LDL receptor related protein 1, has high affinity for ApoE. So just as in the liver, it can pull in any ApoE containing particle. So that's another way the brain HDL ApoE particles get cholesterol into the neuron. Once those hollow particles enter the neuron, they go into endosomes that rapidly convert into what we call lysosomes, which have degradative enzymes. And all of a sudden, they digest those whole particles, creating fatty acids, phospholipids, which break down into fatty acids, free cholesterol. And then they go into the Niemann-Pick proteins, the little endosomes. They're really a protein carrying cholesterol and bring it to where the neuron needs it. Now you see, third from the top, the neuron can also express something that's expressed widely in many of our peripheral cells, the scavenger receptor B1. That also binds rapidly to HDL-sized particles, whether they contain ApoA1 or ApoE. And this receptor delipidates the particle. It doesn't endocytose the particle. So if you follow the green arrow, you see, okay, it pulls cholesterol in. It is rapidly deesterified to free cholesterol, just the yellow circles in my graphic. And then the neuron can do whatever it wants with that free cholesterol. Most of it is going to go to the neuron cell membranes or other organelles within the neuron. Now, if for whatever reason a neuron has too much cholesterol, just as too much cholesterol is toxic to any cell in our body because it crystallizes and causes apoptosis, the neuron has been the one cell that is gifted with ways to get rid of excess cholesterol should that ever occur. And part of the pathology of Alzheimer's disease is too much cholesterol in neuron cell membranes. So if those people have functional receptors here, they might be able to get rid of unnecessary cholesterol in the neuron. So one way, right in the middle, you see the yellow circles can be reesterified to cholesterol ester, which can be effluxed out through the scavenger receptor B1 into ApoE, and you form an HDL particle, and that's an escape route for cholesterol. The second is the neuron can express ATP binding cassette transporter A1, which will efflux excess free cholesterol out into ApoE, and the ApoE cholesterol-rich particle can bring it back to the astrocyte. And by the way, the astrocyte is connected to the blood-brain barrier, but also to the cerebrospinal fluid barrier there also. So there might be exit ways there. The cool thing about the neuron is you see an enzyme called 24S hydroxylase, a member of the CYP450 enzyme system. And what that does is it changes free cholesterol into an oxysterol that's carrying hydroxy groups on both ends of the molecules. I know you need a magnifying glass to see that little white square. That's cholesterol 24S. You see an OH group on both ends of the molecule. In essence, you are creating a hydrophilic lipid. Most lipids are hydrophobic. They hate water, but this is one that likes to be in water, and therefore other lipids repel this hydrophilic lipid. So the neurons are the only cell that contains that enzyme. Astrocytes do not, and the other glial cells do not. So once it, by the way, what is an oxysterol? They're bile acid precursors. I bet you didn't know the brain can make a bile acid. 24S hydroxycholesterol is a primordial bile acid. So because it's so hydrophilic, it can easily pass through the neuronal membrane. It enters the atrosome, the matrosome, and it has two routes. Let's go the bottom route. You see it drops right down, it passes through the blood-brain barrier, and now it's in your plasma. And it rapidly binds to a protein, either albumin or any lipoprotein that is cruising by. And either albumin or the lipoprotein brings the 24S-hydroxycholesterol back to the liver, which takes it and converts it into more advanced bile acids, which get excreted in the bile. I joke with Kellyanne, most people don't know that the brain can excrete cholesterol through fecal excretion. And it does it by creating 24S-hydroxycholesterol, which goes to the liver, becomes a more formal bile acid, and goes out through the biliary tract and your intestinal lumen. Wow. But notice there's another route for 24S-hydroxycholesterol. It can just swim back to the astrocyte and be reconverted to cholesterol synthesis again, or excreted to the cerebrospinal fluid for exit out of the brain. So very complicated lipoprotein trafficking of cholesterol. The last thing I'm going to say is go to the very bottom. I see something in the plasma called apolipoprotein A1, and you all know that is the structural protein for peripheral HDL particles. But ApoA1 is one of the lowest molecular weight apoproteins. The only apoproteins that have lower molecular weights are the ApoC family, and they can do the same thing. ApoE, the molecular weight is too high. Although it's low, it's high enough that it cannot pass through the blood-brain barrier. So any ApoE in the brain's astrocytes make it. Neurons can make it too if they need to. So, but you see, ApoA1 can break through the blood-brain barrier. It may be pulled in by the scavenger receptor B1, which can be expressed at the blood-brain barrier. Perhaps even very tiny primordial, the pre-beta HDL particles might slip through too, but a big, fat, mature, large HDL under no circumstances can enter the blood through the blood-brain barrier that is intact anyway. So interestingly, once ApoA1 joins in the macrophone, the matrosome, it has the size and structure that it's looking to bind to a smaller size lipoprotein. And what does it bind to in the periphery? High density lipoproteins. What does it bind to in the brain? Brain HDL particles. So ApoA1 can also be found on brain HDL particles. Most of the brain HDL particles are ApoE, but they also could be ApoE plus ApoA1, both of them, and they perform very similar functions. They bind to the same receptors, so they facilitate trafficking of cholesterol to the neurons. And it's amazing how this happens. There is a hope that in the future, producing apoprotein A1 or drugs that create lipoproteins that carry a lot of ApoA1, such as the CETP inhibitors, significantly raise ApoA1 concentrations. And there is hope that if we ever got a CETP inhibitor that works and would get approved because of what it does to the ApoB particles, it could be a supplier of ApoA1 to the brain. And when might that be good? Kellyanne hinted at it. If you are making brain HDL particles that carry the ApoE isoform, they, just like in the periphery, you've all heard of dysfunctional HDL particles that don't work. If your brain HDLs carry ApoE4, they do not work efficiently like ApoE or ApoE3 or E2 ApoE proteins would on an HDL particle. So there would be a hope in E4 carriers who have dysfunctional HDLs that if ApoA1 could be sent in, they could rescue these ApoE4 HDLs and perhaps make them a little more functional. That's going to require years of more testing and clinical trials, but that's certainly a plausible theory right now. So it was complicated. There's a lot of similarity to what goes on in the periphery, but that is brain lipid and lipoprotein homeostasis in a nutshell.
So I think,
Favorite,
yeah,
your turn, Kelly.
that was a lot. So, I think what the next question that we often get asked is, like, we spend all this time teaching you about how the CNS or central nervous system lipoprotein system is so separate from the periphery, but yet we also spend a lot of time talking about LDL-C and how that is a quote modifiable risk factor for dementia. And how does that make sense? How are the two related when we're preaching about how separate they really are? So I want to show you this picture because I do think I posted this on my social media recently. I think this is just such a powerful visual to see. It is a little mind-boggling that this picture was published in 2003, and it took us 20 years to recognize that LDL-C or ApoB could be a modifiable risk factor for dementia. So what we're looking at here are the intracranial blood vessels in the brain in something called the circle of Willis, which is really this central larger artery system that perfuses the entire brain. Not the very small blood vessels that penetrate the brain, more of these larger vessels that feed off of the internal carotid and the vertebral arteries. And so we're looking at cross sections here. And the average age of the people in these that were once these vessels is about 85 years old. So in both the top and the bottom. So the top is cognitively normal 85-year-olds. And we got a countdown, 8 o'clock. And the bottom is those with Alzheimer's disease. So it is really, really striking to see just the degree of atherosclerotic plaque buildup in people with Alzheimer's disease. Really, really striking. So I wanted to show that to everyone. And, how does LDL-C or ApoB, neurologists are a little behind the times in terms of what we call high cholesterol. So it's going to be a long time before neurologists adapt ApoB, but how does this potentially contribute to cognitive decline, dementia, and lots of other neurodegenerative disease? Well, there's lots of reasons, probably. One is changes in blood flow and blood perfusion are, of course, changing oxygen delivery, nutrient delivery to the brain, which is, of course, could be putting these neurons, astrocytes at risk. But also the whole inflammatory process that occurs with atherosclerotic disease is not just affecting our peripheral organs, but also we understand that it can trigger neuroinflammation, and neuroinflammation is one of the mechanisms by which neurodegenerative disease occurs. So these are important things, and how we lower ApoB or peripheral levels of LDL cholesterol is important to long-term brain health, even though the way that we're doing that is not necessarily changing how the astrocytes and neurons are cycling or recycling cholesterol. Okay, Tom, should we talk about ways to manage ApoB, since I know that is on the top of
very quickly, since that is such a big risk factor for those blood vessels you just showed there, and which would lead to certainly vascular perturbations up there in the brain. Look, you have to lower ApoB. That means you have to get rid of the particles that are carrying ApoB. 95% of those are LDL particles. And we easily do that by upregulating LDL receptors in the liver, which bind to ApoB and pull the particles into the liver for catabolism. And the more LDL receptors you can express, the more clearance you will have. You will reduce ApoB to much safer levels where that type of pathology should not happen. And obviously, if we got people to those ages, obviously having the non-atherosclerotic arteries was better for your cognition or so. So very briefly, the drugs that upregulate LDL receptors are statins, ezetimibe, and the newer cholesterol synthesis inhibitor, bempedoic acid. And our other drug, PCSK9 inhibitors, extend the residence time of LDL receptors that are made. So with various combinations of those drugs, we can pretty much get LDL cholesterol, non-HDL cholesterol, ApoB to wherever we deem necessary, depending on the overall risk of the patient. And in our very high-risk people, if you ever listen to Peter Libby on a podcast, he'll tell you up there in Harvard in his clinic, he wants LDL cholesterol to be 10. And trust me, he knows he's not injuring anybody's brain by lowering ApoB that much. Now, not everybody needs their ApoB or LDL cholesterol lowered that much. But that's how we lower ApoB. And we've gone over this in other podcasts, so we don't have to spend more time on that. I will mention just quickly, because we're going to get into it soon enough, LP little a particles are a member of the ApoB family, but the LDL receptors cannot bind to, for the most part, and clear LP little a particles very efficiently. So all of those drugs, or the ones that upregulate LDL receptors, do not lower LP little a, statins, ezetimibe, and bempedoic acid. PCSK9 can a little bit, but it's only because it inhibits the synthesis of LP little a particles in the liver. It doesn't enhance their clearance through LDL receptors. Okay, so geez, now if we could only teach neurologists to learn a few of these basic lipid drugs, we'd be in good shape.
For sure. And, there are, as Tom mentioned, several options for treating LDL-C, ApoB, and by and far, the most frequently used one is statins. And we thought it would be worth really discussing this because it comes up so often. What medication should I use? Does it matter if I have the ApoE4 gene? I'm scared of taking statins because I'm scared that they're doing something harmful to my brain, to my long-term risk for dementia. And are there ways to better personalize what type of regimen that I take? So these are the things that we think about all of the time. Like, the punchline is that there's probably no one size fits all for everybody. Depends on your risk factors. It depends on potential symptoms that you experience on the medications. And of course, it depends on what our ApoB target is for you. By and far, statins are the most commonly used medication, and we should go into some of the data on that, because at the end of the day, the data collectively shows that statin use is associated with a lower risk for dementia, full stop, and everyone should really hear that. There's a lot of fear about using statin medications for reasons related to long-term brain health. And while there are, and I'll punt it to Tom to maybe talk a little bit about that, while there are some studies that show that statin use may be linked to worse cognitive outcomes, by and large, the studies really support the use of statins for long-term brain health.
Yes, the real truth is that there's plenty of statin data, and if you do big meta-analyses, it shows two things. Statins prevent no harm to the neurologic system, and in some people, they actually may improve the onset of cognitive impairment or so. But there was an article just published last year by Michael Shapiro, who's a well-respected lipidologist, who said, look, to be honest, we all believe, and the data, like I and Kellyanne just mentioned, is in statins' big favor. That's all observational data of one, and some observational trials are next to useless and some are quite good. So, but there's plenty of them, and the data is pretty consistent. So that is the belief. Last year, there was actually a trial done where it wasn't a long trial for outcomes, but it was elderly people where they were doing cognitive studies. And they actually, there's never been a statin trial, observational or not, where let's just enroll ApoE4 people and see, is there a danger to statins in those people who have higher risk for Alzheimer's disease or not? Or is there benefit? And they separated the people into these groups, and they had a number of people who were on E4s taking a statin and a number of E4 people not taking a statin. And the people who were E4 carriers who took a statin had significantly better performance on their cognitive impairment tests rather quickly. So there should be no fear to ever using a statin. We already told you, even if the statin somehow lowers LDL cholesterol to a scary level, which, depending what the baseline LDL cholesterol was, statins can drop it kind of low. You don't panic at all. The data would be you're doing good. So that is the statin data. We don't have statin data on outcomes in people with LP little a. We do know statins can raise LP little a trivial amount, but at the same time, they're getting rid of all the LDLs not carrying ApoA, so the APO little a. So there is a benefit to statin therapy in people with high LP little a. But what they might be doing, maybe it's time for Kellyanne to start the discussion on what about LP little a in cognition.
Yeah. Before I say that, I also just want to say that, cholesterol homeostasis in the brain is so delicate and tightly regulated, and being on either side of the extreme is probably bad for the brain. We don't want excess cholesterol, and we don't want too little cholesterol for the brain. And the last thing about statins is, of course, we all understand that they cross the blood-brain barrier, and they do suppress cholesterol production in the liver primarily, but they can impact cholesterol production in the brain. That actually might be a desirable side effect. That might be one of the reasons why they're associated with a lower risk of dementia later in life. So I just want to put that out there that, that side effect actually might be desirable. And what's most important to really monitor is someone's cognitive symptoms. There are real cognitive symptoms that can happen in a small subset of patients. And those really are brain fog or slower cognitive processing. And if we see that, then it's a good sign that we should back off that and try something else in somebody.
Let me just chime in a second because I should have discussed that, showing the astrocytes. But uh, what Kellyanne mentions is absolutely true. And the vast majority of people, I think, were doing benefit by prescribing statins to the brain and some partially suppressing brain cholesterol synthesis. Part of Alzheimer's pathology is neurons are overloaded with cholesterol. And so a little bit of reduction of cholesterol would likely be beneficial. But just as in the periphery, in some people, statins can blow away LDL cholesterol, in other people, not as much. And that has a lot to do with how much are they inhibiting HMG-CoA reductase and how much they are producing or hindering the production of cholesterol. So remember, the astrocytes go through the brain block pathway which winds up with desmosterol becoming cholesterol. Interestingly enough, people have done studies showing that brain desmosterol, winds up in the cerebral spinal fluid where it's easily measurable, and desmosterol is easily measured in the plasma. And lo and behold, brain or CSF desmosterol correlates incredibly well with plasma desmosterol. And not only did they show that you could therefore use plasma desmosterol as a marker of brain cholesterol synthesis, but the people who had low desmosterol had increased incidence of cognitive impairment in Alzheimer's disease, which raises the theory that if we measure desmosterol in people's blood and it goes below an arbitrary value, which might call the 20th percentile population cut point, those people are likely under-synthesizing cholesterol a bit too much in the brain. In the vast majority of people who take statins, they feel nothing taking it, but there is a small percentage who get what Kellyanne recently mentioned, brain fog. Any statin prescribers have known people have come back. I don't know, my brain isn't working right since you prescribed the statin. It usually happens very rapidly. One theory might be could that be a person who's a hyperresponder to statins and you're really shutting down cholesterol synthesis too much? I wish we had studies on desmosterol in such patients. We don't. So right now, this whole desmosterol thing is a very attractive theory for a lot of reasons, and it is easily can be watched. And maybe if we do watch it based on this theory only, because nobody's going to do a big randomized trial to prove or disprove this, in our E4 carriers or other people that we deem might be going down the cognitive impairment or Alzheimer's pathway through other risk factors or the E4, might that be the person we really watch desmosterol closely? And of course, we have to lower ApoB in these people because Kellyanne just showed you what ApoB does to cognitive impairment through atherosclerosis. maybe we could back off on the statin a little bit, see if the desmosterol goes back to a more normal level of cholesterol synthesis, or not use statins at all. We got ezetimibe, bempedoic acid, PCSK9. We can get ApoB control very easily without using a statin if we have to. So that's the desmosterol story in a nutshell. A very attractive theory right now. Don't, if you go rushing to your doctor demanding a desmosterol level, he is not going to know what you're talking about. Perhaps you can get some supportive literature, but it's just an attractive theory right now that one day I would hope somebody thinks enough of to look into this. I think with some of the drugs coming along that might be affecting things that affect the brain, that'll be that, and 24-S-hydroxycholesterol will be a biomarker of interest in such studies.
Yes, that's so important. The desmosterol idea is just that. It is a really attractive theory, but it is, we don't know. We don't know if these studies in people with MCI that showed lower levels of both CSF and plasma desmosterol really are just representing that there's this loss of homeostatic cholesterol control in Alzheimer's disease and other neurodegenerative diseases. And that's just a marker of the underlying pathology and not a target that we can really intervene on, if that all makes sense.
Yes, it might be a useful biomarker along with an E4 to say, oh boy, now you got two risk factors for, and then the whole statin discussion is a separate hypothetical theory.
Yeah. And then this was one of the Q&A questions, but it has to be top of mind for almost everyone in this call, including myself, who also has elevated Lp(a). How does Lp(a) impact risk for dementia? What do we actually know about it so far? Unfortunately, I wish I had a great answer. The data is inconclusive. It's a little bit all over the place. There's been studies that show that having elevated Lp(a) actually may be protective and lessen dementia risk. There's other studies that show that it increases AD risk in certain ethnic groups and people with the ApoE4 allele. There's also a large portion of the studies that show there's really no association or really borderline significance, period. So unfortunately, we don't really know how it impacts risk for long-term brain health. It's something that is beyond interesting, and I really hope that we have more conclusive studies on in the future.
The one thing the listeners should know that an Lp(a) particle cannot leave plasma and enter the brain. So it's not like Apo(a) is being delivered to your brain. Even if there's free Apo(a) in the plasma, it has an incredibly high molecular weight. So even a free Apo(a) cannot cross the blood-brain barrier. Personally, I would, like Kellyanne said, and she did a nice review of some of the literature, and I never had looked into this too much, but it is sort of all over the map. My guess is in those where it does occur, it's just contributing to the vascular pathology, atherosclerotic pathology. I would love to know some of those cross sections of those arteries, how many of those people had elevated Lp(a). Now, listen, they were 85. They probably would have had such arteries earlier in life if it was all Lp(a). But so I don't think right now you factor Lp(a) into your you factored big time into your vascular atherosclerotic risk factor analysis, but I don't know. I think we know where to put that as to this help me decide whether you're going down a dementia route or not. I'm going to lower your ApoB right now, which is the treatment. The last thing, and I don't know, many listeners know there are several drugs in development that blow away Apo(a) production and virtually going to take it out of the plasma to very low levels. I wonder if they must be looking at certain neurologic endpoints in some of those trials. They're certainly going to look at stroke, but I doubt they're doing neurocognitive testing in these people. Perhaps they can do it in a post-analysis trial, or maybe there's a subsegment of the trial. But it'd be very interesting and useful to know that.
Yeah, and the studies on Lp(a) really were looking at both the larger and the small vessels of the brain. So the ones I showed you in that cross section, those were some of the larger vessels of the brain. So it does seem like Lp(a) increases stroke risk of the large blood vessels, but that does
Right.
not necessarily increase risk for dementia, which is maybe a little counterintuitive, but that's what the studies show. And unfortunately, I think it's all over the map, and we just don't have very strong data to go off of right now.
But is all vascular dementia stroke, or could just ischemia contribute to it also, where you don't have a stroke, but your blood flow is impaired enough? So yeah, that would be those are the type of arteries that would cause ischemia.
Yep, yep. And it's also, beyond confusing because the diseases are all mixed pathology. In many of the cases, we don't see pure vascular dementia or pure Alzheimer's disease. We see bits of different types of pathology once we do autopsies. So I think the jury's still out. I would say that, hopefully we'll have more information. I think treating LP little a, and at one point in the future, when we have drugs for it, will probably be great for overall cardiovascular disease health. And I can't imagine it's going to hurt the brain.
Sure. Get to some further questions.
So I'm going to just pull up the ones that we had ahead of time, and then maybe we can have Susan or Jen read through what ones are in the chat. So let's see. Is ApoB worse for the brain in ApoE4 genetic carriers, and why? Do you want to answer that one, Tom?
Yeah, because it's easy. I don't know. I think they're both pretty serious risk factors, and they're interconnected in a lot of ways, as we've sort of showed some of the reasons why. So they both can contribute to dementia in their own ways. There's no ApoB in the brain, so whatever ApoB is doing, it's external to the brain. But look, it creates vascular disease. Inflammation occurs due to too many ApoB particles. Inflammation is not good for brain vasculature or the brain itself. So I don't know how you would separate the two. If you're an E4 carrier, I would want to chase ApoB very aggressively, but I chase ApoB very aggressively in anybody who's at risk for either brain or vascular disease. So I don't know how you separate the two.
And at least in the periphery, ApoE4 have increased atherogenic lipoprotein, so it probably isn't good.
That's true. In the periphery, it'd be a double whammy. In the brain, we could blame it all on E4, but we could also blame it on ApoB by what it's doing to the blood supply of the brain.
Okay, one other question that we got: why is greater LDL fluctuation in midlife associated with dementia? So there was this really, I thought, interesting study published a couple of months ago in Neurology. And essentially what it showed was that LDL-C variability, and this is referring to absolute changes over time, in both LDL cholesterol and total cholesterol, either changes up, trending up or down, it did not differentiate, were associated with a higher risk for dementia later in life. In some ways, that's a little bit counterintuitive, because you would think, a trend down of LDL-C and total cholesterol would probably be good for brain health. But I think this is what was really tricky about this study. Just like the desmosterol discussion that we were having, I think what we're really seeing here is that cholesterol homeostasis is really important, and lack of cholesterol homeostasis or disruptions in cholesterol homeostasis are probably a very likely pathway to neurodegenerative disease. And having either too high or too low can be harmful. So I really think that this association, while really is interesting, isn't maybe something that's actionable and more representative of an underlying biomarker of what's happening on a molecular level with cholesterol homeostasis and control in both the periphery and in the brain. I don't know if you have any
Yeah, there
other
was
thoughts.
an editorial with that paper, and the editorialist sort of blamed it on these people have terrible vascular disease, so it's going to be sort of the ApoB ischemic sort of mechanisms going on. At the end, he postulated, or is it that the dementia causes brain lipoproteins to fluctuate? And of course, that was a hypothetical question he answered and says, I don't know, we need studies on that. So look, this was a study in elderly people. This was not young people, and there were vacillations in the levels, and that were significant. So, to me, it's looking at why would a lipid concentration vary you have the genes that are causing the lipids to be abnormal, but the environment controls how these genes affect the proteins they're producing. So, what's the environment? Nutrition, sleep, exercise, a lot. What else were these people doing or not doing that might have changed their, and if it was poor sleep, that would be something that might worsen dementia or so. So I don't know. I think there'd be a lot of other variables you'd have to look at.
Okay. Are there currently any studies looking at low cholesterol synthesis in the brain, causes and consequences? So I know that you've lectured me extensively on desmosterolosis and so forth. I think maybe that might be helpful to talk about.
No, if there's studies looking at that, I don't know about them or so. If in any of the big trials, there's a trial that are ongoing, STAR-E, and I think the one is called Preventable, which is looking at statin use and cognition and everything in older people. It would be wonderful if they were also measuring desmosterol and 24S-hydroxycholesterol in those studies, because we might get some more information on this. So I don't know. I try and talk to a lot of the young people I know of, my friends at the NIH. You got to be looking at this because this, who knows? You discover something like this is Nobel Prize winning type of material because it'd be such useful information. And it'd be just as useful to say it's a total waste of time to even measure that as far as how you're modulating it with lipid drugs. We just don't know. So,
But we do know that there are people with genetic issues with cholesterol synthesis, and that
yes,
could
there
lead to
are.
problems.
Yes, and they're pediatric diseases where kids have genetic defects, including not converting desmosterol to cholesterol, not converting lithosterol to cholesterol. So these are kids who, in utero and throughout early childhood, have very low cholesterol levels. Many are born with neurologic defects or born dead. There's a lesser called Smith-Lemli optic syndrome, which is an inhibition of one of the enzymes in the cholesterol synthesis pathway, where the cholesterol is quite low, not low enough to kill most of them, but most of them do have neurologic issues or learning disabilities and things like that, which would prove low cholesterol is certainly, as measured in the periphery, might be injurious to the brain, but the same enzymes are involved with cholesterol synthesis in the brain too. So just as those particular things, this is not a mother taking statins during pregnancy and screwed up the fetus's brain, or a 2-year-old being put on a statin, a 2-year-old who doesn't have familial homozygous FH. So yes, there are certainly worries that low cholesterol in the brain would not be good.
All else equal, which is a greater risk factor for dementia, metabolic syndrome or dyslipidemia? Can they be separated? High ApoB, low triglycerides. So I know you have some thoughts on this. And
Yeah, well, certainly metabolic syndrome is just a bunch of markers that are indicators of underlying insulin resistance. And insulin resistance is one of these big contributors to dementia. So that's where that would come in. Virtually everybody who's insulin resistant, depending on what sort of testing you're doing, would have lipoprotein abnormalities. Uh, and typically they do have high triglycerides. Somebody high ApoB and low triglycerides. It's not every metabolic syndrome has a high triglyceride, uh, but there's much ado about this keto study ongoing now, where people on a ketogenic diet send their LDL cholesterol through the roof, their ApoB through the roof, but their triglycerides drop. And the theory was, oh, and these are people where high LDL cholesterol isn't hurting them. Just published was an imaging trial that showed, guess what? Their imaging using CTA got significantly worse over just a short time period. And look, if their arteries are getting worse, and those are coronary arteries, something tells me their brain arteries wouldn't be too healthy otherwise. So, there are other thoughts that ketosis can maybe help the brain in kids with intractable seizures. 50 years ago, they showed a ketogenic diet can certainly stop seizures, and therefore that's a beneficial brain effect. but I don't think we have much else on what ketosis is doing to dementia or not. You'll go on the internet and see, oh, my grandpa was demented and I gave him a ketogenic diet, and the next day he woke up and was fluent, and those case studies of one. So just we
And
need more studies of everything.
from my experience, I've also had patients report the same thing. They went on a ketogenic diet, they felt amazing cognitively, and they went on a ketogenic diet and felt terribly cognitively. I think that there's so much more nuance than we can fully recognize, and we're not always very good at predicting who will do well on what medication or what dietary intervention and so forth. And I know this doesn't exactly answer the question that I just asked, but I thought it was worth showing. So I mentioned before these 14 modifiable risk factors that were published in the Lancet Commission report in July of last year. And what we're looking at here in terms of percentages is the population attributable risk. So essentially what we're seeing here is that high LDL cholesterol contributes to about 7% of dementia cases. So if we eliminated that, we would theoretically prevent about 7% of dementia cases. And then looking down at things like diabetes or hypertension and obesity, they actually seem a little less impactful, but it's so hard to disentangle all of these various risk factors because they really are interrelated in so many ways. But I thought this was interesting to show.
So I want to thank both of you before we get to the other questions, and just say that this was a phenomenal presentation. I know that we've had some really wonderful comments in the chat, that this was a really exceptional masterclass for the doctors that are here too. And I know that it may be a little over the heads of some of the lay people here, but we will have the recording and we can keep studying everything that you said. So for now, I'd like to get the recording. I'd like to stop the recording, and then you want